I am PY Cho, and I think I'm the organizer of the ICC. Today, we are so happy to have Professor Maria Meazzini with us. We have two very special moderator panelists as well, Professor Adam Cole and Professor Yifang Liao be with us. And I also invited Professor Betty Pai be as one of my co-moderators. So later in the beginning, Professor Pai will give the short introduction of Professor Maria Meazzini. We are so happy and honored to have Professor Maria to be one of our important speaker for our Congress of the Chang webinar in the Chang Forum this year, 2022. So I have to introduce Dr. Bai. Hello, Dr. Bai.
Hi,
yes.
everybody.
Please.
Yes.
Yes.
Okay.
The short introduction of Professor Maria.
All right.
You.
Okay.
Yes, please.
Let me introduce. Yes. Okay. Let me introduce Professor Maria Meazzini. She is a scientific director and orthodontics consultant for craniofacial anomalies at Cleft Palace Center in Operation Smile, Italy, and Santi Paolo E. Carlo Hospital in Milano, and at the Department of Craniofacial Maxillofacial Surgery, San Girato Hospital in Meazzini, Italy. And she is also a adjunct professor in craniofacial anomalies for the residencies in maxillofacial surgery and orthodontics, University of Milano. And she's also president of a European Cleft Palace Craniofacial Association and a representative and for the European References and Networks. And she requires a specialties in orthodontics and dental facial orthopedics and a master in medical sciences from 1991 to 95 in Harvard University. She also completed a craniofacial and surgical orthodontics fellowships from 1995 to 1996 in Chicago, Illinois. And she did also the trimester internships at Chang Memorial Hospital, Tokyo Medical Dental University, and Gio Garcila's Hospital in Mexico for further craniofacial training. Let's welcome Professor Meazzini. Meazzini? Yes.
Almost. Meazzini.
Meazzini?
That was perfect.
Okay. Okay. Sorry.
That was almost perfect.
Thank you, Professor. Yes, please.
Do you want me to start?
Yes.
Okay,
yes.
Wonderful. Okay, thank you for the presentation and thank you for the great honor. Thank you, PY, for inviting me. It's being back after 25 years, even though not live, is an amazing honor for me, and I'm really almost moved by the idea of being back. It's really great. I dared to change the title a little bit, so I added the sentence, why is cleft orthodontics different from traditional orthodontics? Because to me, it is so important to understand that it's not the same. I've heard over and over again, surgeons and orthodontists telling me, well, there's not much of a difference. It's not true. And that's actually one of the reasons why, and thank you for allowing me to talk about the course later on. I was so excited about organizing a course because as an orthodontist, you really need to know at least what not to do in cleft and craniofacial children. Because if you, what is this? Yes, I accept. There it is. If you don't know what you're doing, you are one of the ones who, as an orthodontist, can increase the most the burden of care of these children. And if I put this, do you still see the full screen, PY?
Yes, it's still full screen. Yes.
Okay, perfect. And so what I would like to do today is go through every step of our roles as orthodontists and see where we have to know what we're doing and where, if we don't know what we're doing, we have to keep on striving to understand better. And I would say that the first role of an orthodontist, not in terms of importance, but in terms of temporal role. So the first thing that we do when we're in a cleft center is pre-surgical infant orthopedics, if we do it. If we start that, we have to really understand that we want to see whether what we're doing is improving growth or actually it's hindering it. We have to check that out. We have to know whether we really improve the surgical results or we're actually only improving our ego. That's another very important issue. And we really have to strive to separate facts from fantasy every time we do something. When it comes to infant orthopedics, if you go back to the reason why in the 70s, like more than half of the centers in Europe had passive plates, and many centers in the States as well. A lot of centers in Asia were using plates, infant orthopedics, because that was the era where we were hoping that by changing function, we would change form. So the idea behind a plate was, okay, then the patient would swallow normally, and therefore little by little gain normal functions and therefore grow better. But then in the 90s, a Dutch cleft study came out. And that to me was a very important study because it made me think a lot about what I was doing. And it was a randomized study, so very high level of evidence. And what they told us was, is that true? Do plates make these kids grow better? And there are lots of criticism behind the study in terms of the way they handled the plates, but the thing is they had a plate, so the swallowing pattern was normalized. And no matter what, these kids did not grow any better transversely. They did not grow any better in terms of posterior anterior growth. They did not eat any better, but we knew that already. And they spoke better only, they had a better articulation till 2.5 years, but not after. So when I came back from the States and Japan and Taiwan, and I started working in Milano, the protocol had 100%. So every single child got a plate, and I started reducing that little by little. But at the same time, in bilaterals, I started a completely different thing, because I think that bilaterals are a different type of pathology. Somehow they should be always separated from unilaterals. And the thing is that when you have a bilateral, you have this protrusive premaxilla. And yes, you can get it back surgically, but then you might hinder growth very much. Yes, you can get it back with more active retraction, but then again, you could have growth problems. And you could do a lip adhesion, but that's an extra surgical process. That's an extra general anesthesia. So you really want to get it back as softly as possible. And you can even just use a tape if you want. Remember that was early 90s, and I came back towards the end of the 90s. So Professor Brusati was my surgeon, still used no primary surgery of the nose. He would get beautiful lips, but the problem was that snubbed nose with a very short columella and really no projection. So by the time these kids were 5 and they went to school, they needed to get what was the very best solution at the time, which was a secondary lengthening of the columella, which can be a nice surgery, especially immediately. But with time, in many of these children, it becomes, as Malikan used to say, a secondary deformity. So in the 90s, and remember the time frame that we're talking about. So we're talking also about history of clefts in this. The 90s was a time when a lot of these primary surgical approaches to the nose started coming out. And one of them was cutting and Grayson's. And the difference between this one and the others was that there was a pre-surgical columella elongation, so an orthopedic phase, and then a primary retrograde nasal reconstruction. And I had the luck of training with Dr. Figueroa in University of Illinois, and then he went to Rush. He had already modified Dr. Grayson's technique a little bit, and then I modified it even more so that I could get, or we modified it even more, so we could get the premaxilla back, lengthen the columella at the same time, but see the patient once every 4 weeks and not once every week, as the Grayson technique initially said. And because we had no evidence at the time, what we needed at least was a rationale. And the rationale was there because we just talked about the Dutch Cleft study. It says it doesn't improve growth, but it doesn't inhibit it either. So that was a good point. And then the second point, which was very important to my surgeon, was tissue expansion. You get so much stretching of the nasal lining that then when you have this nose to operate on, you're going to have, or at least he said he had an easier time to access the cartilages and do the primary surgery of the nose. So we started that, but of course, the first question that we asked ourselves, okay, is it worth it? We see the kids after surgery, they look great, but is it worth it? Is it going to reduce the burden of care? And so the first question that we asked ourselves was, okay, are they going to be decent at 5, which is the time when normally we would do a secondary lengthening of the columella? And so we checked these kids at 5 and we compared the new protocol to the old protocol to a group of non-cleft age-matched children. This is my son, and you'll see him over and over again. And well, our main concern was, is a columella long enough not to need columella lengthening? And it was. It was practically normal. So we went on doing this thing, but we went on studying our patients. And this is one of our patients at 5 and the same patient at 12. And this is my daughter at 5 and my daughter at 12. So we did the comparison at 12. And what we saw was that, interestingly, the columella not only grew in terms of growth, but it grew in terms of the correct proportions to the nose. What you already see from this slide is that, unfortunately, at 5, the nostrils were wider, but the nostrils still were wider at 12. And we kept on studying these kids, and we just published a year ago the data at the completion of growth, following our kids till they were adults and comparing them to those famous non-cleft children. This is my son at 20. So the group of non-cleft adults were my kids' classmates and my kids who were taken for pictures every X number of years. So longitudinally followed kids, what we saw basically was that tip protrusion is really not different. They had a really good protrusion of the nose. The columella doesn't grow as fast in reality. When you get to the end, there's no difference in terms of statistics, but clinically there is some difference. Whereas when it comes to width, these kids have wider nostrils and wider tips. So as you will see afterwards, a large percentage of our children in the end, once they get to adulthood, they want some touch up of the nose. The other, though, important question, and you see, this is a nice nose in terms of projection, but it's a little bit too wide in terms of tip and in terms of base. The other question was, do they grow skeletally, though? Because I've been asked over and over through the years, yes, but probably because you do the NAM, they're not going to grow as well. And so we took our patients and the previous protocol. And the good thing about these two samples is that the surgeon was the same. The palatal surgery was exactly the same. The alveolar surgery was exactly the same, and the lip surgery was exactly the same. So they were absolutely well matched. And there was absolutely no difference in terms of skeletal growth. So we can say, this is the only thing that we can really say, that neither NAM nor the primary surgery inhibits craniofacial growth. And that to us was already an important thing. What we cannot say is whether NAM by itself really improves. So we know that NAM plus the primary columella surgery improves the length of the columella so much that we have avoided completely the secondary columella lengthening at 5 years of age. But it's not a randomized study, so we can't really say whether NAM is the issue. And I will leave that to all the randomized studies that you probably know are starting in India, where they have so many patients that they can answer the question. So I have decided to present only the data on bilaterals because I have very little science on unilateral, and Chang has a lot more, so it wouldn't be interesting for you. And I would go now to actual cleft orthodontics. And the typical question that we get as orthodontists, not only by the surgeons, but also especially by the families, when should we start? And I know it seems silly, but the answer that I usually give is because we don't want to overtreat these kids, we should start when it's really needed. And we will talk about all these steps in the course, but not today, of course. So I will concentrate especially on the preparation for bone grafting, because I think that's where an orthodontist can do a lot of mistakes, also in the rest, but in this instance, a lot more. So if we're in mixed incision and we are treating a child who has a protocol that has within the protocol a secondary bone grafting, we have to be able to have the perfect synergy with the surgeon. And unfortunately, I think this is one of the instances where an insufficiently trained orthodontist can do a lot of harm and unknowingly increase in a very important ways, as you shall see, the total burden of care of these kids. So there are 3 points that I'd like to make. The first point is, if your surgeon tells you that he has no need for more access, or for example, if you have a child who was operated elsewhere and there is a fistula, and by doing an expansion, you're going to enlarge the fistula and make it difficult for the poor surgeon to close it, then do not do any expansion prior to bone grafting. And I'll show you one example for each of these things that I'm telling you. So don't worry if it sounds a little bit mysterious. For example, this kid was sent to me when she was 6 by her general dentist, who told me, oh, it's very important that you expand because otherwise the mandible is going to grow completely crooked. And aside from the fact that, we'll talk it another time, maybe that is not true, but if I had put an expander in her case, it was too early for bone grafting. And look at here, there was I wouldn't even call it a fistula, it was just a non-complete union of the hard and soft palate. So I would have definitely created a passage between the mouth and the nose and given her a lot of problems. And maybe I would have had to do a plate to sort of close this area in the meantime while we were waiting for the bone graft. So basically what we did was wait 3 years, and when she was ready for bone graft, she closed also the fistula at the same time. And then once she was closed, I put an expander in and I started derotating this central incisor that you see here, and also from the front. So while we were expanding, to keep the burden of care as short as possible, we derotated the central incisor that needed it. So just a quick rotation and then blocked the incisor. But we have plenty of no bone here, so we could derotate this tooth and move it with ease and without any fear of doing any damage. Then you wait for the permanent teeth to come in. And so she had this permanent lateral incisor coming in. I don't care about transposition, I just leave them. The canine was erupting here. The permanent premolar will take the place of the canine, that's not a big deal. And you align those teeth normally. She had a little crown on the lateral incisor. And in a very short time, she finished her alignment. She was a good grower, so she kept this good occlusion. And as you will see in a few cases, the only thing that she has is a slight vertical relapse in the area of the cleft. And that's something that you will see more than once, with good stability in the long term. And you'll see whenever I can, I'll show you long-term results, because I think that's very important. This to me is like top-notch important aspects, incisors and secondary bone graft. If you're starting as an orthodontist working in a cleft team, go with your surgeon in the OR and look while your surgeon is doing a bone grafting, because you will see how little bone that this poor tooth has before bone grafting, and how easily you might do damage if you move those incisors before your surgeon puts the bone in here. So do not move these teeth unless it's absolutely essential. And I will show you an example why. Because you will risk root damage, but more than root damage, which is less, you can, but it's less scary. The very scary part is creating big time periodontal defects. And I have one very good example, which is actually a patient that I've never seen, but I was sent by my surgeon, a good surgeon that I work with, this picture. And I said, oh, okay, it's a little bit late for the lateral incisor, but that's fine. I have to take some teeth out, and then she or he can put bone grafting and then do the orthodontics. But unfortunately, what had happened, this was an old x-ray, and I was sent the results of the orthodontics by the same surgeon. And he showed me what had been done. So basically the orthodontist had waited till he could put straight wire brackets on, brought down this poor central incisor into the arch, and he thought he had done a great job to align the teeth and prepare the patient for bone grafting. But look at what had happened. This is a tooth that I've shown you before. Most of this area of bone is now denuded. So when your poor surgeon puts a bone graft, part of it is going to be lost, not because he's not a good surgeon, but because it has nothing to attach to. So please, this is really very important. Be careful with the teeth close to the cleft. And there's a third important point. When you need expansion, because you decide together with your surgeon that you need to expand, or you need to do when do you need to do expansion or minor orthodontics, right? When the segments are not aligned, so that's a good reason, and your surgeon is always going to ask you to align the segments, or very often, and when he just can't access, he has a hard time accessing. So I'll show you examples of both. This is a girl that I treated many years ago, and if you see, the lesser segment was collapsed, as it sometimes happens with many protocols. So I used, I don't like very much helixes, but I used it at the time. They can be very good instruments. There's nothing wrong with them. I'm just lazy. And what we did here was getting the lesser segment aligned with the larger segment so that the bone graft was put. And as you see, the tooth was erupting a little bit palatally, so it was brought into the arch, and the canine was lateralized, and the patient was super stable 12 years after treatment. And then that's interesting also because I took away the fixed retainer that she had because she wanted to get a proper face set on the canine. She never got it actually, but what happened by taking it out, she got that vertical relapse that I talked about 16 years after. But I had the luck or the privilege of seeing her smile at her wedding, so that was more important to me than a stupid tooth. But anyways, but that's for the alignment of the lesser segment. But there are exceptions to moving the teeth. And with all the attention and the care that I've told you about, sometimes you need to do it. And this is a good example. This is a girl that had done primary periostoplasty in central Italy in another center. And what primary periostoplasty does sometimes for you is it doesn't ossify where you need the bone, but it ossifies up here in the nasal floor. Probably you've seen it. And what happens when you put an expander, you don't open the space between the lesser segment and the larger segment. So what I needed to do after that is put brackets on with lots of care in order to have the roots into the bone. It's actually even more into the bone. And so that then my poor surgeon could have good access to put bone into the area that needed to be grafted. And that's for the protocols that need bone grafting. When you have a protocol that does not have bone grafting, or maybe has a very early secondary bone grafting, like they do in Paris, in France in general, they do early bone grafting at 5-ish. We do early secondary gingival vulvoplasty, which is a gingival vulvoplasty done at 2.5 years of age. So later than primary, so it has a higher ossification rate. It does influence negatively growth a little bit, but it has at least a very good ossification. But no matter which of these protocols you have, what does an orthodontist have to do? First of all, check if there's ossification. You could do it with 3D, you could do it with 2D, but you have to check. Once you're sure that you have a good ossification, then you have to treat the patient, but you have to treat the patient not as if it were a non-cleft patient, but also always as if it were a cleft patient, because it is a cleft patient. So in this case, I had checked for ossification. There was good bone here, and I wanted to create space here. And so what I did was overcorrecting the expansion, and I overcorrected it not only because I didn't want to put any retention, but also because, and I have not much evidence for this, but I have only my clinical evidence for this. When you overexpand, the canine tends to move a lot more mesially. And that's what I wanted. I wanted that canine to move mesially into the area of the lateral incisor that was missing. And by taking out the baby teeth little by little, you have a natural mesial movement of the first premolar, natural mesial movement of the second premolar. So once you put braces on this poor kid, he has a lot less work to do. And the result that you get in the end is a lot more stable, because at 24, he still has a nicely sucked in occlusion. And look at the periodontal support around this canine, which has been transformed. It's absolutely perfect. And so this is very good to introduce this case, to introduce the next question for an orthodontist, that every time you see a patient who's about 6 with a panoramic X-ray, and you realize that there's a missing lateral incisor, and this happens in 55% of your patients, the parents and the surgeon ask you, what should we do? And I usually say, well, we'll wait and see, which is what I do. But in general, it is true that between the positioning of an implant and the positioning of the canine, I do now prefer to put the canine, because the literature helps us a lot in that direction and tells us that both in terms of periodontal health and in terms of risk of infraocclusion, putting the canine instead of the lateral incisor is actually better. Although you shall see there are exceptions in which I decide to put an implant. So this is a case that resembles very much the one that I've just shown you. The canine had naturally erupted into the area of the lateral incisor. There was still a baby tooth that hadn't been taken out. It was taken out before orthodontics. You could see that there was a nice thickness of the bone, but by mesializing the canine, you get an even better thickness of the bone in the cleft area. And so we could mesialize and get a good occlusion with a very decent midline correction. Not to the face, but at least to the teeth. And with this is still the composite that I did is quite horrible, but he never wanted to do a better reconstruction. He could have, he still has time to do it, but he has a nice stable occlusion at 23. And what I always say, maybe you shouldn't be too paranoid about midlines. You can still have a very good looking face with a midline which is not perfectly on. As I said, I have exceptions to the rule. This kid, for example, had a class 3 malocclusion on this side, class 3 premolar, canine was class 3. And so instead of mesializing everything where I would have had to use TADs, maybe 2 TADs, reposition it, longer treatment time, we decided with a surgeon that I work with, the surgeon that I work with in San Gerardo Hospital, to open up the space. He says he's also very good at putting implants. So I did a much shorter orthodontic treatment by expanding and creating the space. And so I created enough space for Dr. Mazzolini to put a nice implant. And at 22 years, you see that periodontal status is good. And support of the upper lip is very good, and smile line is very good. So you can do it, but you have to pick the patient. It has to be a patient that has a shorter treatment time when you do that. Now I will rapidly go through, I had also some examples like in terms of intrusion of the premaxilla, other aspects where the orthodontist can be useful to the surgeon, but you've heard it before, and I think that's a little bit more new somehow, is helping the surgeon when there are large lacks of soft tissue. And so this kid was operated in sort of middle northern Italy, in a center where the type of surgery that they do somehow doesn't allow, they always have this distance, whether I have another case in permanent dentition with the same problem. So what he was proposed in the same center was to do a premaxillary setback and bilateral bone grafting at the time. And the family was informed that by doing that, then he would have had full class 3 malocclusion, like with a complete class 3, and then he would have needed either distraction osteogenesis of the maxilla or a later osteotomy of the maxilla. So what we did was exactly the opposite. What we proposed was exactly the opposite. This is a child, it's a growing child, so sutures are all completely open. So we simply put a silly face mask and an expander, a simple expander, and advance to lesser segment with no surgery. So this is not a distraction osteogenesis. This is a sort of distraction osteogenesis, but it's a distraction osteogenesis with no surgery. And you close nicely the soft tissues so that then your poor surgeon can, from here to here, operate on this area and put the bone graft bilaterally without the fear without the need to get that premaxilla back and create all the damage that you know would be secondary to the premaxillary setback. This can be done also in unilaterals if you have them young enough. And I'll show you one example. This is a little girl with a large alveolar cleft. But if you see the CT scan, these sutures are beautifully open here and sutures are beautifully open back here. So no distraction osteogenesis, no major flaps to close this large soft tissue opening, just an orthodontic appliance and advance the lesser segment and get the lesser segment in a position that you see here, that the soft tissues, you see that this piece and this piece are now together, and the surgeon can now close it easily. And at the same time, he can put a bone grafting, because by the time we had advanced the lesser segment, the canine had developed to 2/3. So by the time we took off, as you see here, the expander, he could put the bone grafting and close the soft tissues at the same time. So the orthodontics can help the surgeon, but you have to select cases, and in some cases, it can even make the burden of care lower instead of making it worse. And the last topic that I'd like to rapidly go through is patients with a class 3. And it's a shame that Eric is not here because a lot of is in his honor. But when we have a child with a class 3, and we know that even if you have a good surgeon, and I had a very good surgeon with a very decent protocol, a certain % of your children are going to grow into a class 3. And you'll see it a lot more when they're 10-ish, and by 11, 13-ish, they'll go a lot worse. And by the end of growth, they'll be ready for orthodontic surgery. Now, the question is, should we treat them early? And is it true what I was taught when I was a resident in Harvard? And Harvard is not like the place where silly people usually go and study. At maxilla early, I would improve the prognosis of these kids. Of course, remember that was 30 years ago. So we have to understand whether that is true or not. And to understand, you have to go back to what's the instrument that you use. You usually use, to advance early the maxilla, you use a face mask. And a face mask is an unbelievable instrument. I mean, if you think that the person that invented it was a German guy 150 years ago, you have to be a genius to think about it. 150 years, think that by grabbing onto the teeth, you can actually elongate the sutures. I mean, it was a very intelligent idea. The thing is that there are limitations to this instrument. And one important limitation is that it works fine at 6, 8 years of age because sutures are all very open and you can help a little bit with the rapid expansion. But then by the time the kid is 10, 11, that thing doesn't work any longer and you get tooth movement, but not really skeletal movement. And even when it does work, so in a very young child, if you look at the actual movement, you're getting 2 millimeters of advancement. And again, when you talk to your surgeon, you tell him that you've advanced maxilla 2 millimeters, he looks at you and says, thank you, honey, but it's not particularly exciting. So, and there's a third, a lot more important disadvantage. To me, that's a main limitation. And the main limitation is that when you do it like at 7, 8 years of age, by the time the kid is 10 or after 2.5 years, he's going to have exactly the same proportion that he had when I started. So you've done this for what? So I will just show you one example of a child that was treated in Milan. Started before I came, but that doesn't matter. It's the principle that matters. At 5 years of age, he got his first face mask, then got orthodontic treatment between 5 and 10, then a second face mask, and then orthodontic treatment between 10 and 15, and then orthodontic treatment between 15 and 18. And by the time he was 18, he was ready to be decompensated, to be prepared for orthodontic surgery. I mean, to me, this is not acceptable. In 2022, well, it wasn't acceptable then, but more so now, it's not acceptable. This is a burden of treatment that is all orthodontic. So it's not the surgeon's fault, it's the orthodontist's fault. And this to me is really not acceptable any longer. And so to go back to the question that we were asking before, like, does early treatment, this is what I was taught, early treatment changes growth prognosis. Is it true? And to give credit to the right people, Ross was the first one to go and honestly look into that. And he said, no, early treatment does not change growth prognosis. And then the Europlast study, Sam and Shaw, they said the same thing. And we published a study that I liked very much, but not many people read it, but please do read it. It's a study where we had patients that had exactly the same severity when they were 5, 6 years of age. And some of them, because they were treated all over Italy, some of them had very early and continuous orthodontic treatment, and some didn't. And eventually they had the same exact pattern. And so the answer to this question is an absolute total no. We do not change prognosis when we treat these kids early. So don't put a face mask at 5. It's not going to change prognosis. Other exceptions? Yes, in everything there is an exception. And sometimes I do put a face mask, especially I like the medical indications. I had the privilege of writing the preliminary results of the study on ENT problems and advancing the maxilla. And what we have seen is that if you have a child with recurrent otitis, very often, because of the fact that they go to school and they can't hear properly, the ENT surgeon puts a tube so that the mass of liquidy, solidy stuff goes out of the tube. But if you expand the palate and bring the maxilla forward and stretch the tubal dilator muscles, you open the pharyngeal orifices, and then this disgusting stuff can go down the right way. And actually what we saw with Professor Felizzati, who's our ENT surgeon, was that you could go from problems with hearing, these are not particularly severe, but a severe problem with tympanogram, to a total resolution tympanogram type A bilaterally and perfect hearing. And we published that, I think, a couple of years ago in otology. But that works even better, and we're writing it right now, when you have not only expansion, but also protraction. Why? Because you improve also the breathing and the inflammation of the nasopharyngeal area. Therefore, the stability is better. You also have the same mechanism of stretching the tensor veli palatini and letting the liquid come down the tube, but you also have a better breathing associated to it. And so in a child like this that I would have never treated, who has recurrent otitis and hypoacusia, I did put a face mask and expander, and look at what happened to his tympanogram and his acoustic, his hypoacusia. After the advancement of the maxilla, you have perfect tympanogram and perfect hearing, and a stable, perfect hearing and perfect tympanogram 2 years after, although you may notice that there is already some recurrence of the class 3. So I don't care about the skeletal recurrence. I care that he has been hearing very well at school without putting a hole in his eardrums. Obstructive sleep apnea can be another interesting aspect, but it's more for other syndromes than for clefts. You do have it sometimes in clefts who have a pharyngeal flap. That can happen. We have 3 kids who have a pharyngeal flap and AHI over 15, and just by expanding and bringing forward, surgeons know it very well because they heal the worst. Like when we have craniofacial children like Crusoe and Aperts, they can have a 45 and 50 of AHI, and after distraction they become a 0. So we know that surgically you can do it, but you can do it also orthodontically, and within the 20 of AHI you can really do a very good job. as was done in this Tricia Collins child with the cleft palate, who was totally improved because just a few millimeters expansion improved nasal airflow 5 times. But the last question then is, okay, these are exceptions, but can you do it in a stable way, orthodontically and not surgically? But what you need is something that works later. And this is very important because if you look at the growth curve of girls, you shouldn't start before 12, 12 and a half, 13, because that's when the growth curve really slows down. And in a boy, it's actually later. You shouldn't start before 13 and a half, 14, because that's when the growth curve slows down. If you start here, then you're going to have a few years that are going to just cancel what you've done. And to honor Eric, what I'm using is actually a modification of his brilliant idea. He used this double hinge expander, but the idea is not expanding the arch, it's just breaking the sutures that at 12, at 13 are starting to fuse. And he used, he came to talk in 2000, and you can see that it was 2000 because this is my son that you've seen in many, many pictures. He's now 22. And this is Flo, and she's probably now 23. And so they're about 6-7 months apart, I think. And when he came, he definitely converted me to this idea of opening and closing. He did not convert me to the idea of these springs because they break all the time and I don't have all the help that Eric has. So the modification was, and of course I can't take lower teeth out because you know that Caucasians are flat, so you can't flatten them out even more. So the modification is, well, I always look at CTs because sometimes you have bone bridging before I do this open and close. And I do the open and close the way Eric does, just a couple of weeks more than he does. And the protraction forces are a little bit lower. And that's why I go for a couple of weeks extra. And I put TADs in the lower and in the upper, sometimes 2 TADs in the upper. And never take teeth in the lower teeth out because we're Caucasians, we can't accept flattening of the face. We can't support it standing. And then you can come with that maxilla forward and downward. And actually what Eric thanked me about was the fact that I published the long-term results of these kids. The advancement was a little bit less than he does, but not bad, more than 5. So it's still a number that you talk to a surgeon and says, that's pretty good, not bad. And the long term was pretty interesting because in females, it means that only 2 girls out of 10 have a recurrence of the class 3. And because you have introduced no dental compensations, they can decide to have the best aesthetics by getting surgery or have less aesthetics, but still a good occlusion by taking teeth out, for example. In boys, it's different. You really, and I'm calculated only the 20 plus because before they're 20, you can't say a thing in boys. So only 6 out of 10 are stable, but the others can do dental compensations or deciding together with the surgeon or surgery. And some of them decide not to get surgery, some of them, and we prefer it, do. And you can do it also in non-cleft non-cleft patients, for example, other syndromes which are not craniofacial synostosis, of course, and get good results in terms of advancement. And this is a girl that I've shown you before. You do not start at 10. You have to be patient and start at 12 and a half, 13. And then you get this result, but that's not what's important. What's important is that at 24, she's perfectly stable. She doesn't brush her teeth. She has a really terrible hygiene, but a very stable occlusion. And same with this kid. And that's an interesting study that we're carrying out with Dr. Rizzoni, who's our speech pathologist, seeing if there is any difference when you advance so massively, only orthodontically or compared to surgery. And there seems to be problems sometimes also with this technique, but not as much as surgery. And this kid who had borderline speech and a lot of scarring, he was an adopted child, could get a nice 20 plus stable occlusion and stable skeletal results, but especially a nice stable smile, good lip support at 20 plus. So when we know that that's what he's going to retain for the rest of his life. So I do thank you for your attention, and this is to me so important. We should help the surgeon reduce the total burden of care and not increase it. And if there are any orthodontists, please, you have a couple of hours, no, and not a couple of hours, but not too many hours left to register. We will talk about especially what should not be done in these kids, and not only these kids, because my big passion are actually croissant and apert kids, and they get treated even worse than cleft kids. So I am very passionate about what should not be done in those children. And we'll talk also about what Ellen is very passionate about, hemifacial macrosomia. There's 2 days for hemifacial macrosomia, because those are also kids that deserve our full attention and our full devotion. And if you're surgeons, you don't give a damn about this course, please come live in 2024, or if you're speech pathologist, live. We want a lot of people from Chang Hospital. We could do a nice evening for Chang people that I adore still after 25 years. And for all the others, please do come in 2024. We'll try and make it a superb Congress for all of you. Thank you.
Yeah,
I'm done.
thank you. Yeah, thank you, Professor Maria. Yeah, thank you for you remind us a lot of the memorable photos with the previous beautiful time with our Professor Eric Liu, and thank you for you share your children's the photo with us, and thank you raised a lot of problem, and all those problem has very good solution by your hand. I think later we will invite our 2 panelists to come to give us some comment. The first of all, one is the Professor Ellen Cole. Hello, Professor Ellen.
Hello.
Yes,
Dr.
please.
Costanza, it's really appreciate that you show long-term result. I think I think we are in similar generation. In this generation for the class.
Oh, you're younger.
We have underwent a lot of innovation and things. I think the first one, we have learned to do the nasal alveolar molding. And I think it's a time that when I was in fellowship in UIC, and it's really the first time we see the nasal alveolar molding. And at the same time, Dr. In NYU, they have a lot of, Dr. Grayson, they have a lot of promotion of this technique. And later, at the time, we underwent with the distraction osteogenesis in mandible and the maxilla. And in the same time that the conventional way that they're always debating about the maxillary expansion in the cleft patients. Yeah, some of in the traditional one, some have mentioned about that we need to expand before alveolar bone graft, but we didn't do this at Chang. And I'm really happy to see that Dr. Costanza, you have the similar way that we take care of the bone graft success first, and then later we check, we have something to do with the arch form, that's the later. So I think the primary goal of the treatment in each step is quite very precise, and also produce less of burden. And I think that is quite similar. And I think I appreciate your talks and the experience sharing. And I would like to ask Dr. Costanza, you have mentioned about that it's quite good experience about using Dr. Liu's technique about the alternate maxillary expansions. Do you have a long-term result? And from your long-term result that you have say that 80% of female is quite stable, 60% of male are stable. And from this long-term, do you think that, do you have your own criteria to categorize the patient who will go for this treatment or who will go for orthodontic surgery? The reason why I ask this, because the health insurance in Taiwan, we only cover only once in the lifetime for orthodontic treatment. So we need to really select a good timing for the full mouth orthodontic treatment? And what's your comments or recommendation about that?
Well, aside from the money issue, which is important, I understand we have national healthcare covers for everything. So we don't have to take a decision based on the coverage, but still having so many years of experience, I can tell you that it's a difficult procedure. It's difficult for us as orthodontists because it's like a dear friend, Daniela Garib, she uses the plates in the lower and in the upper arches. That for an orthodontist is a lot simpler, and she's right. You know, you send the patient to the surgeon, he puts the plates, and then the child carries elastics for years and years. But she's very honest about her data, and she shows that she only gets 2.5 millimeters of advancement, and a lot is mandibular rotation. So that technique somehow is more restricted to less severe patients because you don't get all that much advancement. This technique allows you at least a couple of millimeters extra. So the 5 millimeters that you get on average, so whether it's 4, whether it's 6, is almost a surgical movement. But it's at the expense of a lot more trouble and a lot. So you have to have a parent that understands that he has to open and close, and that's not as easy, not for all patients and not for all parents. And you have to have a patient that really asks for it. So I think the selection criteria are patient who is there and asks you, I want it. If the patient says, you can't tell a patient, okay, it's the right thing to do, you do it, because he needs to cooperate, and he's going to, it's painful somehow, not very painful, but it's definitely bothersome when you open and close and open and close. While closing, they feel as if their face was disrupting. So if it were my child, I would do it only if they asked me, not if they didn't ask me. Thankfully, a lot of kids, because that's the, girls at 13, they really want to look prettier. So they come and they say, okay, I know you told me I'm going to get 2 screws up here and 2 screws down here. I want to do it because I want to get better. And then they get excited because they see the improvement little by little. Shaky idea, especially males, I would definitely, especially because males are not as successful, so you cannot guarantee that much success. I would tend to only do it on the males that really ask you to have an improvement. It happens. They talk to the psychologist before, so I will always have them talk to the psychologist before I start. But let's say that 20 years ago, I was more aggressive. I would sort of start a treatment even just because the mother would ask me. Now I wouldn't. Now I would ask the child, and I would kick the mother out, kick the father out of the room, and have the girl or the boy talk to the psychologist, because it's a difficult, it's a difficult procedure. And the other thing, at the beginning, I was hoping that from the velopharyngeal standpoint, they would have no problem, because most of my patients had some temporary velopharyngeal insufficiency, but then it would come back. But we're studying them now with Dr. Rezzonico, and some of them have an increase of the velopharyngeal insufficiency of the IVF and maintain it. So you have to be honest to the families and say that maybe it's less, but we're not sure still about that. And so I would say if it's not the selection, aside from, of course, the measurements, if you have a child who already has a 10 millimeter problem, you're just going to leave him alone and let your surgeon do something. Because if he has 10 millimeter discrepancy at 11, that means that by 20, it's going to be a 15 millimeter discrepancy. So that's too much. So I would use numbers as well, never more than 8 millimeters of discrepancy. That's about it. So psychology, kid asking because it's hard for both, and millimeters. So big selection, not every kid can get it.
Thank you.
Okay, thank you, Professor Ellen Go. Thank you, Professor Costanza. And next, I would like to invite Professor Yifang Liao. Yes, Professor Liao, please.
Thank the professor's lecture. I really enjoy, and I have 3 questions for you. First, what's the possible reason of columella widening after your nasal molding? Because
sorry, do you want me to reply now?
yeah, because in your lecture you say after nasal molding you found the patient's nose become wider, so they have to receive the secondary nasal revision and they grow up, right? I just wonder the patient had the widening of the columella after the nasal molding.
Well, not really the columella, the tip of the nose and the alar bases. But if you compare to the data with Malikan, for example, Malikan only does his Malikan technique, primary columella lengthening technique, and he also has very wide nostrils and very wide tips. So I don't think it's the nasoalveolar molding which widens the nostrils and the tip. It's just that they're bilaterals and they have wide nostrils and wide tips. What happened a few years ago, like it must have been 8 years ago, no, more than that, 12 years ago, sorry, we invited at an Italian meeting, Grayson and Cutting, Dr. Grayson and Dr. Cutting. And Professor Bruzzati was at the time my surgeon, listened to Dr. Cutting's lecture and came to me and said, you know, Costanza, I think I will change my surgical technique and it will make our noses narrower, because we had already published the 5-year results and we had seen that the noses were wide. So he said, I know what I should do. So he said that the problem was surgical technique. So the week after I didn't see him, 2 weeks after I didn't see him, 3 weeks after I finally see him and I say, oh, wonderful, Professor Bruzzati, what's the modification that you want to do? He looked at me and he says, oh, I don't remember. And so that was it. So we never changed it, but it might be something that can be improved, not by us, by changing the nasoalveolar, because I tend to try and get those nostrils as closed as possible, but it might be something with a touch up with the surgical technique. It's a possibility. I don't know. I don't even know if it's possible. I'm not a surgeon. Maybe PJ wants to say something about it, but I remember this thing from Professor Bruzzati, which was hilarious because he never told me what he had thought because he had forgotten it.
Okay, may I interrupt for a while? I want to invite Professor Low to give us some of the aspect of this as a surgeon. Okay, please, Professor Low.
Hello, Dr. Low.
I think Professor Liao still have 2 other questions, right?
Yeah, I'm back. I have to turn off the camera.
Professor Liao.
The connection.
Okay,
The second question is the second question is, what's the clinical indication and the latest timing of maxillary protraction? And because you emphasize the importance of the sutural patency, do you routinely perform the combing CT before the treatment? And what are the important factors for the success of maxillary protraction in addition to the gender and the timing? Does the force duration among all type play important role?
Thank you so much for this question, because that to me, like, we are carrying out 2 different studies now on sutures in cleft lip and palate, and we're actually doing a collaboration with Mette Kupers, who's the daughter of Anne-Marie Kupers-Jahrman. And because there are some kids, especially the ones that have done bone grafting, but not only, that may have early sutural closure. So I, of course, use all the typical timings that we use as orthodontists, so the vertebral stage of maturation, and maybe the fact that menarche is almost there in a girl, or the boy has a little mustache. But then now I always take a CT scan, and I've published a paper on the plastics, or on the Cleft journal in craniofacial synostosis, where you see that they're all closed, all the sutures. But I think it's important to see it also in cleft patients, because I've had 2 girls where I wanted to start with the technique because the girl wanted to. And after I saw the CT scan, I said, I'm so sorry, but we can't do it. The sutures are closed. And actually now, right after the COVID, because many came like a year and a half too late, I had to say no for the same reason. So thank you, because I believe that's fundamental. When I was younger, and maybe I didn't think enough, I didn't use my brain enough, I don't know, but I never talked to the parents about the idea that there might be the risk. I would just look at the x-ray and say, oh, if she's B2, B3, perfect, I'll start. And then I would have, they would start opening and closing, and the expander would drop down, and I didn't understand why. And that was probably because there were, at the time, I didn't check it with a CT, but there were bands of bone that didn't allow for expansion. So I think, aside from the typical signs that we look in terms of a cone beam CT scan is good enough to do a good reading of the pterygomaxillary and the zygomatic maxillary, and the mid-palatal suture is always open no matter what, so that's less important.
And what's the latest timing of maxillary protraction in your experience?
That I've done it, but I think it's so variable, because it depends on like, I've had girls at 10 that couldn't do it any longer because they were from Arabic family, so they tend to mature a lot earlier. And the latest that I've done was a 16-and-a-half-year-old boy, but it's hard to put an age. I think it all depends on the scalpel maturation that you see on the lateral x-ray, and then especially on the CT scan. So the latest, I think, was just by chance that the sutures were open.
So how about the clinical indication? You mean the maxillary hyperplasia about 5 millimeter?
No, not more than 8. Yes, never more than 8.
And how about the growth pattern or the overbite? Do they influence the success?
Yes, I tend to overcorrect. This was, especially because I thought this is Chang, so you've seen too many of these things from Eric. I didn't show much of these, like to show you the overcorrections, but you need to have almost a class 2. I remember when this big professor from Jordania came to visit and saw one of my cases, he was horrified. He said, you can't. Now he's a deformed child. He's a class 2, a severe class 2. And I'm like, well, wait 3 years. He won't be a class 2 any longer. And he wasn't. So you have to overcorrect a lot. Definitely. Thank you, actually. This is also an important question. And I have not shown it because I thought this is your world. So I'm just showing a little piece of what you do.
Okay, the third question is, I just want to know the instance of orthodontic surgery in cleft patient in your center, and what's the surgical protocol of cleft care in your center, including the timing and technique of nose, lip, palate, and alveolar repair. I'm curious about this.
No, thank you. So for unilateral, let's say cleft lip and palate, but it's the same for bilaterals. We have a first step at 6 months, where now it's Dr. Otilitano, the surgeon who has taken Professor Brusati's place, and where you close the lip, do the primary rhinoplasty, and do the soft palate. Then at 2.5 years of age, when the alveolus is molded and closer and closed, and the hard palate also is very close, you do the hard palate, and this, what I called a secondary gingival vuloplasty, which is sort of closing the periosteum and the gingiva and getting a very nice watertight closure so that then bone migrates. And there's pretty high success. Of course, against the success rate of the ossification, because the closure is done at 2.5 years, which is after the peak of palatal growth that Berkowitz talks about, but still quite early, we do have more inhibition of maxillary growth, and we've published a couple of studies, one against Oslo and one against our previous protocol, and we have about 28% need for orthodontic surgery, so close to 30%, whereas Oslo has only 15% to 15% of need for orthodontic surgery. And so did Professor Brusati's protocol before, when he had a 3-step surgery. So Lippen, soft palate, hard palate, and then instead of doing the gingival vuloplasty, he used to do the bone grafting at 9/11. So definitely the bone grafting doesn't inhibit growth, whereas this protocol does inhibit growth, at least of a 10%, 15% more. But that's the reason why Professor Brusati liked the ultramic technique, the modified ultramic technique so much, because we could reduce it a lot in females and quite a lot in males. So now the total burden of care, taking away the ones that have done the ultramic and therefore don't need it any longer, is about 20%, a little bit less.
Okay, thank you.
Okay, thank you, Professor Liao. And then we'll follow by Professor Low, please. Thank you.
Hi, Dr. Costanza.
Ciao.
It's a long time no see, and
Long time.
And great to see you again.
How are you twins?
Oh yeah, I actually enjoy your talk very much, and it's showing that how important that a Cleft team should really have a good orthodontist to work together. We are lucky in Chang that we have a very strong orthodontic team. And listen to your talk, I can imagine that your team also is a very nice, multidisciplinary team. And as a surgeon, I always feel that orthodontic can help the surgeon from the baby name or alveolar bone graft, and then the orthodontic surgery. So the whole course orthodontic, in my team really help surgeon a lot, or even treat our unsatisfactory result. So this is to show that in our audience there's also other team that just to tell them that it's very important to have a good orthodontist in the team. Now I do have some 2 questions for you. The first is that you mentioned that before the alveolar bone graft, you mentioned that the incisor, you do not correct the incisor in the real accurate position. That could bring the dental root very laterally, or even out of the bone, out of the bone. But what when we do the bone graft, will that solve the problem? Because in our team, since that we pre-ABG orthodontic treatment, we always do a good alignment. I don't know. Can you explain this, or our orthodontic team can also help to explain our treatment policy?
Well, the alignment of the teeth before has to be done with a lot of care. What I've shown is an extreme case, because there are cases where the patient really has very little bone on the lateral aspect of the central incisor, and then if you move the root, it doesn't even take the bone with it. Sometimes it just perforates it, just as it does on the vestibular aspect. So what I meant was that if you want to touch those teeth, you have to have a lot of experience and a lot of attention. And in a lot of cases, I really wouldn't dare touching. We discussed this at the International Cleft Conference in Edinburgh, and we had sort of 10 extra minutes to talk, and there were quite a few orthodontists who did alignment, but there was a presentation by an American orthodontist that was really interesting because she showed unknowingly that she had a lot of loss of bone in the more gingival part. So somehow the bone grafting done with the alignment was not as successful in the gingival margin as it was in the patients that had not done movement of the teeth, and those were large numbers. So although there are patients where you have a nice thick bone, and you do, and so you're lucky you can do whatever you want, you have also patients like the two that I've shown that have very thin bone, and in those cases you're going to do sometimes just a minor problem and sometimes a major problem. So my point was, be very careful, and you have to know what you're doing, because not all patients have a nice thick border of bone. Many of them have a very thin, like the ones that I've shown you, and you can do a total disaster in those cases.
Okay, thank you. And then the second question is that you talk about secondary GPP, and I guess that this is in the early childhood stage, maybe before the ABG. Am I correct?
That's actually at 2.5 years, between 2 and 2.5, together with hard palate closure. So you have a virgin hard palate, and you close together with the hard palate, you close also the periosteum of the alveolus. And that's possibly the reason why the success is so high in terms, we only have a 5% need for bone grafting. Because when you do it primarily, there's still one center in Italy and not many centers around the world. There's, of course, New York. They have a much lower ossification rate, especially if you consider that the data that they've published is data taking away those patients where alveolar molding was not successful. So if alveolar molding is not successful, they don't do primary periosteoplasty. So the data that is published is a little bit biased. So they have 40% success, but only those that were complete touching. So primary periosteoplasty in general doesn't have that high success, but I think first because it's more difficult for the surgeon, because you have a teeny little mouth and a teeny little thing, and so much more difficult than a 2-year-old big baby. And the other reason is that you're not closing the hard palate together with the alveolus, and that helps a lot because you're opening everything up, getting all the periosteum together, and you get also a much nicer ossification.
So that's a 2.5 years when you do the palate repair together.
Yes, exactly right.
Okay.
Exactly.
Thank you.
Right.
That I think that makes sense. And also the last point is that thank you for introducing the millennial meeting in June 2024. Please remind us when the time is closed so that our Chang'an team can visit the city and join the meeting.
Thank you.
Okay, please.
That will be great. I will remind you every month.
Just
I will send you a mail every month.
Please.
Yeah.
Yes.
Thank you.
Of course.
Thank you. It was so great to see you, Dr. Low.
Thank you,
Professor Low. And then I think that Dr. Bai will select some questions in our chatting room for the Q&A section. So yes, please, Dr. Bai. Thank you.
Yes, it was a wonderful lectures. There are some questions from the audience. Can you share more about the using the mask, facial mask?
Yes.
Hello. Yes. Yes.
Sort of general indications.
Yes.
Okay. So as I said, I would not use the mask in a regular class 3 at let's say 7 years of age, who has no trauma or no no particular request from the child, because usually at 7, 8, they don't give a damn about, sorry, they don't care about having crossbite. I would use a face mask if there's a severe trauma, for example. But I would tell the parents and the family that in 2.5 years, the child is going to be exactly the same class 3 that he was 2.5 years before. I would use a mask in the case of patients with hypoacusia. So if my ENT surgeon comes to me and says, I don't want to put a hole in the eardrum of this kid, you try, I would put an expander and a face mask and protract the maxilla, and we're having a pretty high success rate. So between 65 and 75% of these kids can hear properly after the procedure. But again, you have to tell the parents that you're doing it for the ears and not for the face. So the class 3 will come back on. And I would use it in the very rare cases that these kids have an AHI which is high. Maybe they've had a flap and so they have sleep apnea. In that case, I think it's a good indication. I know those cases that I've shown you where you have maybe patients operated elsewhere and you have these big soft tissue defects that you want to close with the tissues of the child. So you don't want the surgeon to need to put a tongue flap or one of those horrible flaps that they put. So you'd rather put the kid's tissues together, do it orthodontically, and then send the kid to your surgeon so he can close nicely and do the bone grafting or not do the bone grafting, depending on what the objective is. But I think these are the only exceptions where I would use the face mask. Not in some centers, you have a class 3, you put a face mask. Okay. Absolutely.
Okay, thank you. Okay, another question. Have you ever encountered any breakage problems when you're using orthoramics, and how do you prevent it or solve them?
I have bands breaking, a few times the expander breaking. At the time when I used for a couple of years Eric springs, they were always breaking, so I don't use those any longer. I just have to do as if, you know, it happens also for normal expanders. They break sometimes, usually not at the level of the screw. Although the screw recently hasn't been breaking any longer that much because my technician makes it very solidly, but bands can break, and that's a problem, and we have to just take impressions and redo the appliance. And oftentimes, by the time the appliance is done, you have to, first of all, you have to wait for the maxilla to collapse, then you retake the impressions, and then you do the appliance, and you have to start with the open and close again. So I have encountered problems, and they can be solved, but as everything in orthodontics is always bothersome, and the families think that you're stupid when the appliance breaks, and that really makes me upset, because it's not really the orthodontist's fault. It's that in the mouth, anything can break in the mouth, unfortunately. That's our job. It's the wrong job to choose, unfortunately, but we have it now.
Okay. Okay, thank you.
You're welcome.
And I'm just wondering, I have one question for you. You don't recommend using NAMs for the bilateral cleft lip palate because of the it doesn't improve any projection and nose projection and width of the nostril. That's the one that you compare between the cleft patients and normal patients. What about, do you have any data when you compare the cleft patients with a NAM and without NAM?
Unfortunately not. That is, well, yes, in the sense that the first study that we published was at 5 years with the previous protocol, and the NAM protocol, and then the non-cleft patients. But the previous protocol had no primary surgery. So when you don't have a primary nasal surgery, I don't think it's fair. It's not a fair comparison. So what we would need is a sample who has NAM and primary surgery without NAM. Unfortunately, in Italy, we have, if we're lucky, 5 new cases per year of complete bilateral cases. So we could never randomize this way. So this is the new randomized study that they're doing, and actually Anne-Marie Kuipers-Jagman is organizing it with the Indian Cleft Lip and Palate Society, and they're doing a huge Indian randomized study where they will have, because also the other fundamental aspect is you have to have the same surgeon. You can't have one surgeon doing no NAM and primary surgery and the other one doing primary surgery and NAM. If the surgeon, one of the two surgeons is not as good, then the results are going to be stupid. I mean, useless. Right. So you need the same surgeon, the same primary surgical technique, and one patient does NAM and one patient doesn't. And that's the only way you can give an answer. And in Italy, we could never do that. So we don't have the numbers, but that's what the Indians will tell us in a few years, because they're starting now an amazing randomized study. Yeah.
See, okay. So thank you. For the next questions, if you have a differences in height between premaxilla in both lateral segments and bilateral cleft patients, how do we manage it? And should you plan shorten the volmars?
I don't know. I can show you. I shortened the presentation, but in the presentation, there's the way I intrude the premaxilla.
Right.
I don't know. Would you like to see it?
Sure, of course. Yes. Please.
Then what I can do is I will not share any longer.
Okay.
I will take my presentation and free up the slides and then just share those slides. Oh, it's a shame. I didn't want my presentation to be too long. I'll be in a second. I'll be back in a second. Give me 1 second.
No problem. Yes.
Okay. Here, at least one case. I will show you just this one patient. Okay. And then I will share this screen. Oops. Desk. I'm still sharing this one. No, I want to share here. Okay. Share. I'm here. I'm coming. Okay. She's here. I think that's what you meant, correct?
Yes, got it.
Okay. Can you see it? Full screen?
Yes.
Okay. This is just very rapidly. I have used many years ago, like 20 years ago, Eric's technique to intrude the premaxilla, but I had the impression it was even too much. So this girl that I've treated a few years ago from Romania, I have treated with a technique that I devised a little bit later, and that has the advantage that you don't have to see the patient too often. So you just put a bonded expander in the back, and so you can do it also in poor dental hygiene like this girl, and then a bonded cap for the baby teeth in the front. I use a bonded cap also if I have permanent teeth, and I try to protect them because I don't want to have emergencies with brackets detaching. And then I just change thick night-eye wires. So it's very soft, very slow intrusion. So you don't get the intrusion like with Eric's level arms in a very short time, but you get the intrusion in about 8-9 months, a year. and you can get this type of intrusion, which is sort of an intrusion, but also some extrusion of the lesser segments. And you want them to extrude a little bit because you don't want to lose too much height of the maxilla, which is always a problem then in the future when they grow up. And the result is also very good from the aesthetic standpoint, so they can close their lips, and that's what they asked for. Because the first girl that I treated, she wanted to be treated because at school they called her hot dog because this thing sticking out was like a hot dog. So I would do this before bone grafting, and then I would let the surgeon do the bone grafting. We have cases though. We have a 13-year-old kid that I always show when I do a lecture in premaxillary intrusion. When the kid is already that old, you might as well do everything surgically. But it's demonstrated that at that age, you don't impact on growth too much. Yeah.
Yeah, that was amazing.
Thank you very much, and thank you for giving me the opportunity. I have hidden a lot of because it was a little bit too long.
Yes, that's great one. And with the next question, yeah, what's your opinion about anterior maxillary distraction?
I don't have any personal experience. Any of my Indian friends use it, and I think it's great if you have the right type of problem. So they often have maxillas that I've never seen in my life, with a lot of scarring in the middle and all these teeth one on top of the other. So you mean the AMD, like the when they do the cuts and then the expander. I've seen some really nice results from India, but I have absolutely no personal experience, so I wouldn't be able to tell you. But the cases that I've seen, the best ones were the ones where you had the teeth. So the ones where then you need to put 2 implants per side, I think that's the burden of care, which is too high. I would do a regular distraction in that case. But when they have so many teeth, some results are amazing.
Okay, let's see. Okay, and do you have any experience or any considerations for Asian patients? And is there any cases when you do extractions, just like, for example, like decayed tooth or teeth? Yes.
Yes, we have now, because mainland China 6 or 7 years ago has opened the adoption for children with some kind of pathology. So they allow adoption only of children that have something. And so parents tend to adopt more frequently cleft patients. So a lot of mainland Chinese children operated, maybe they've done only the lip in China, then get operated again, get adopted in Italy. And so we have a few Asian children in treatment. And in that case, because they tend to have biprotrusive profiles, I accept extracting lower teeth and getting less proclined lower incisors. Also because they are at that point included in a class, let's say, with all Caucasian kids, so they want to look a little less flat, a little more flat. So it's also the kid himself that asks, can I have a little bit flatter lower lip? And so yes, in that case, I do tend to extract lower teeth. That was a question, correct?
Yes.
Okay.
Yeah. Okay, I think, thank you, Dr. Bai, for your QA moderating. I think now time is limiting. So I know we have still remain a lot of questions want to have the answer from Professor Costanza, but I think I will collect all the questions for you, and probably soon I will invite Professor to come give us the answer again, because today time is not too much. Yeah, but I have to announce not only the Milano's, the 2024's, the Cleft conference as well. I have introduced one of the very important online webinar from Professor Maria Costanza. That one is the ECPCA Craniofacial Orthodontic course. Namely is the ECPCA 2024. I think only probably 1 or 2 hours left to be as an early bird to register, right, Professor? Yes?
Yes, well, you have a little more. It's going to be at midnight our time, so another 6 hours. But if you want to sleep, you better do it now.
Yeah. So probably, Professor, you can introduce this webinar yourself to let us.
Oh, thank you.
Yeah, please.
Well,
go ahead.
I'll just take it, put it.
Yes.
I'll go and get it. And as I'm sharing.
Good.
Thank you so much. That is really sweet of you. So it's a yearly course. There are 10 lectures. The first 5 on cleft lip and palate treatment. So the first day is going to be in November, and it's going to be about nasal-velar molding and growth and how to interact with your speech pathologist and other questions early on. Then there will be a second day on mixed incision orthodontics, bone grafting. There will be surgeons talking about very different ways of closing. So there will be primary periosteoplasty, early secondary gingival-veoplasty, early bone grafting like the French do, and then normal bone grafting and how we as orthodontists should interact. Then there will be a day in general orthodontics and how to interact with the surgeon, and then one day in orthodontic surgery. And and the last day, number 5, is going to be tricks and traps. So little things that have no evidence, but where we can have tricks and traps. And then there will be 2 days on hemifacial microsomia, 1 day on craniofacial synostosis, and in September 2023 will be the last day in rare anomalies. So Beckwith-Wiedemann syndrome, Pierre-Robin sequences, for example, plates, not plates, and other rare craniofacial anomalies like also achondroplasia that I'm very affectionate to. I think they can get a lot from orthodontists. Thank you so much for giving me this time. Thank you, PJ.
Wow. This is what a fantastic programs. Yeah, it's online, right? So it's worthy for all
online.
Yeah. So
and if you're going dancing and you can't follow it online, you can always look at it recorded. So there will be a recorded set. So you can go dancing in Taiwan and then go back and listen to it recorded.
Yeah.
I remember the dancing in Taiwan was awesome. I used to go dancing a lot. Do you remember, Dr. Lo?
Yeah. Worthy for all the participants in this webinar to join for this online webinar as well. I think that we have sometimes I want to collect all of our participants' smile. Okay, please turn on your screen and then we can have a group photo with Professor Costanza in this very valuable timing. Thank you very much for all of your participation tonight or in the morning. And I will count to 3 and please give me a gesture, yes, heart, or you can give me triumph, anything. Yeah. Hello. Yeah. Dr. Lu, Dr. Yishen. Okay. So 1, 2, 3. I will count cheese. 1, 2, cheese. Yeah, very beautiful smile. And the next page. Okay, once again. 1, 2, cheese. Okay, great. Thank you. Thank you, Professor Costanza. Thank you, Professor Ellen Ko, Yifang Liao, and thank you, Dr. Bai. See you.
Thank you.
Soon, and see you next time. And please go to register for the online meeting for Maria's.
You were such a sweetheart. I adore you. Thank you so much.
Okay.
You're really nice. Thank
you.
Have
a good day.
Thank you.
And have a good trip, Professor.
Thank you, Panyun. Thank you.
Bye,
Thank you, Ellen. Ellen, that was great.
Thank you.
Thank you.
Thank you.
Bye-bye, Dr. Lo.
Bye-bye.
Great seeing you again.
Mm-hmm.